Everyone out there across Australia and wherever you are. My name is Christine McCartney. I'm the Director of NCIRS and I'm your hostess for today, I guess. I would also like to welcome everyone here in the seminar room with us at NCIRS. So we have about perhaps about 40 to 50 people here in the seminar room and many, many more joining us online. So firstly, I would like to acknowledge the Darug people, the traditional owners of this wonderful land on which we're living, and it has been theirs for 65,000 years. We would like to very much acknowledge the elders past, present and future of the Darug people. We have really a second seminar on flu today. So I'm sure out there many people are very actively involved in rolling out flu programs. They might have launched yesterday or today officially, but today is the 1st of May. And following on from an overview of influenza last month, we have 3 wonderful speakers today that are going to talk quite a bit more about pediatric influenza. This is particularly topical. You're going to hear a lot about it in different regards, and also see a focus on influenza in children with underlying medical conditions, high-risk medical conditions. So we have had a slight change in our speaker lineup, but today it is a great honour to be able to introduce 3 speakers in a row. And maybe what I'll do just for the sake of time is to introduce them all now with respect to their bios. They're going to then stand up one after the other, and we're going to save questions until the end. And it is important for our audience remotely to remember that you can type in questions. Well, you can send in questions anyway, somehow. And we will audit those questions and we'll present them to the speakers at the end of the seminar. So please do join us with some questions as well. So firstly, I'd like to introduce Associate Professor Nick Wood, a staff specialist and vaccinologist here with us at NCIRS, also at the University of Sydney. And he leads the New South Wales Immunisation Specialty Service and Adverse Events Clinic here at Westmead, particularly interested in maternal neonatal immunisation. I would like to very much welcome Dr. Holly Seal. So Holly's a Senior Lecturer at the School of Public Health and Community Medicine at the University of New South Wales. Holly is an ex-NCIRS member as well, of course, but really leads a wonderful stream of work now that focuses on improving awareness and acceptance of immunisation, with a particular focus on at-risk groups and also including adults and healthcare workers, migrants and refugees. Sam Carlson's also agreed to present for us this afternoon as well, and Sammy's worked extensively in our social research area as a research officer, but she's also recently commenced her PhD candidacy using multiple approaches, so a mixed method approach to understanding attitudes about and access to influenza vaccination in hospitalised children, so particularly children hospitalised with influenza, working across our national paediatric active and enhanced disease surveillance network. So it'll be really exciting to hear about Sammy's work funded by the NHMRC today. So I'll hand over to Nick first, then Holly, and then Sammy. Thank you, Nick.
Thanks, Christine. So as Christine mentioned, we're going to try and focus today on the vulnerable children, how best to prevent them from getting influenza. And just finished World Immunisation Week, which ended on the 30th of April. So today, the week after, hopefully some more profile about vaccines has been raised globally. And as we go into our flu season, this should be a timely talk. So we're going to go through in my little talk a bit about how much flu there is circulating, and then I'm going to talk to you about the safety of the flu vaccines and what we know from this year's flu vaccine data, the effectiveness of the flu vaccines, a little bit on coverage, and then I'm going to hand over to Sammy and Holly, who are going to talk to you about how we can improve our coverage. So this is a slide you've probably seen before, and unfortunately our case was up the top here, one of the children that died from it, but there's a large burden of disease from flu. In many cases can be just mild respiratory tract symptoms or can end up in intensive care and hospitalisation. I think one thing that we probably do need to work on is how we can make people more aware that flu can be a very severe disease. So this is the data showing hospitalisations for flu in Australia, and like you know already, most of the disease is in the under 2s, Hospitalisation burden is much higher in the under 6 months, and then it goes down to the 6 months to 2 years, and then slowly declines until it starts to rise again in the elderly. Indigenous children are hospitalised at a rate which is twice that to non-Indigenous children. So we need to make sure that we're protecting our Indigenous kids particularly. This is data showing the hospitalisations at Children's Hospital Westmead and Princess Margaret Hospital, and the same idea. The bulk of the admissions are in that very young age group, under 2s. Unlike the elderly, most of the children that get hospitalised with flu don't have chronic medical conditions. Our New South Wales Ombudsman's report, which was tabled in Parliament in 2016, talked about the childhood deaths that were from vaccine-preventable diseases. And of those deaths, most of them that were potentially vaccine-preventable were flu and meningococcal. And the Ombudsman had a series of recommendations that came out of that report on how to prevent these deaths. In terms of the severe burden of flu in children, as I've shown there, mortality is not that common, but when it happens is obviously extremely distressing. But about 10% of kids can end up in ICU. A significant proportion can end up on a ventilator, either different forms of ventilation, and a small proportion needing a very highly intensive or specialised treatment called ECMO. Children can also have seizures from flu, and influenza-associated encephalitis is very well described as well. Not that common, but there's been a lot of work done by the Paediatric Active Enhanced Disease Surveillance Team to describe on these influenza cases. Most of the children stay about 2 days, but some of them stay much longer than that. In terms of the burden of flu, this is data showing over time notification rates throughout the year, and as you know, there's a flu season which sort of peaks around about July and August. In 2009, the flu season came a little bit earlier, peaking in the July period. In 2017, which was a very bad year, you can see there the number there around about the 100,000 mark, and peaked in August. In 2018 was a much lower year, as shown here. Now, whether the decline in the 2018 was because of increased vaccine, or just that people had been immune, or was just a less disease year anyway, we weren't not too sure. This is data showing hospitalizations, and the same story here. You can see in the dotted green bar here, the 2017 hospitalizations, and then in the red line, the 2018. So there was a much lower presentation for hospitalizations. This is all ages. And in terms of hospitalised cases at the PEDS network, which was those 6 sites, tertiary paediatric hospitals, 2018, a much lower burden compared to 2017. So there's certainly less disease last year than there was in 2017. What this means for people's awareness and understanding of flu and how that impacts on their ability or desire to take the vaccine, we're not too sure. People may say, oh, last year wasn't such a bad year. Flu's gone off my sort of frontal consciousness as much as it was in 2017. I may not get vaccinated, which may mean that we have to work harder to get people more aware of what flu is and what it can do to you. Now, the other thing to say is that the flu is circulating, and there is what we call interseasonal peaks. So this is data from Queensland, and you can see here that there's this normal winter peak here, but it's also peaking towards the end of the year. So there's unusually high interseasonal activity in Queensland. This is data from the emergency departments in New South Wales, and it's showing respiratory illnesses, people presenting to an emergency department with respiratory illness or fever. And the black line here is the line showing the weekly ED counts, and it's a little bit above previous values at the similar time of year. This is data from the Immunisation Coalition on their website. This is also showing in the green line here. This is the flu notifications from the NNDSS, and the green line shows that there is some sort of interseasonal flu happening as well, much higher than previous years, as shown on this particular graph. So that's a little bit about the burden of flu and what we know. In terms of effectiveness of the flu vaccine, this is data which is courtesy of Alan Cheng, and this is vaccine efficacy over time. And the first thing to notice is that vaccine efficacy does change from year to year. It slowly trended down to 2016, 17, but then jumped up again in 2018 to a vaccine effectiveness of around about 75% in the children aged 6 months to 15 years. Jocelyn, one of our PhD students here at NCIRS, is looking at vaccine effectiveness in the very young infants, those under the age of 6 months, and she's using a case control test negative design to look at that. This is to try and improve our understanding of how effective maternal vaccination is. And you can see here that in the first sort of 10 weeks of life, maternal vaccination effectiveness is around about 53%. This was information from 2017 data. So that's the effectiveness story. In terms of how safe the flu vaccine is, we've got a couple of ways to measure this, and one important way is an active surveillance system called AusVac Safety. Many of you will have heard about this particular system before. It uses two sort of systems, one called SmartVax, the other called Vax Tracker, and there's many surveillance sites around the country, and they're actively following up flu. People have had the flu vaccine and then asking them to report whether they've had a reaction or not. This is the summary data from the 2018, and you can see that there was nearly 170,000 people who responded to surveys. This is showing you the percent that responded with any adverse event in the red, and the medical attendance is the blue line down the bottom, and it's according to age. And this is very similar to what we saw in 2017. Around about 6 to 7% of people are reporting any adverse event, and less than 1% are reporting any medical attendance. So that is in line with what we know and how the vaccine performs. So that's the 2018 data. The rates were low and within our expected ranges. And so there were no safety signals identified in this year. So this year there's been a bit of a change in the flu vaccine strains. The four strains that are in the quadrivalent vaccine are shown here. A change in the type A H3N2 and the B from previous. This is a table which is hopefully well known to you now, particularly those that are out in the community vaccinating, showing you the brands and the age groups for which they're recommended. So because the vaccines can change from year to year, and because there are new products that come in and then registration ages change, it's important to continue to do the safety surveillance. And so this has been happening for the 2019 system, and AusVac Safety is proud to show its new website. You can find the link there, ausvacsafety.org.au, and on there you'll have lots of rich information. And what I say to people when I give talks to the providers is that when asked by a parent, so doctor, what's the safety of the vaccine? How's it going this year? I heard there was a problem in Perth about 7 or 8 years ago. Is this vaccine still, a big worry? I say to the GPs, pull up this particular website on your computer, turn around, show them the website, and you can show them these figures that are there on the graph. And they are really quite easy to follow. So we've got run you through these ones. This is this year's data up until the 21st of April. And this is already over 400 pregnant women who've had the flu vaccine have completed the survey. And you can see here that the event rate is about 5.8%. Again, most of them are injection site reactions. Medical attendance about 1%. So if you're a pregnant woman wondering whether the vaccine in 2019 is safe for you, here's hot off the press data as of about 9 days ago. Here's 200 children who've already had the vaccine in age 6 months to 3 years. Event rate about 6%. Again, most common things are injection site reactions, a bit of fever and rash, and not many having medical attendance. And in the 3 to 5 year mark, again, just over 260 kids who've had it, event rate about 8%, predominantly injection site reaction and a bit of fever. So this is, real world, up to the minute data that you can show as a provider, the people that are coming into your clinic to get the vaccine. So that's a little about vaccine effectiveness and safety. In terms of flu vaccine coverage, I put it to you that there's more work to be done in this space, and we can do better. In terms of flu vaccine programs, USA and Canada have had child vaccine programs since the early 2000s. Western Australia had a program which was funded since 2008. In 2014, there was an Indigenous program put on to the National Immunisation Program. And last year in 2018, the jurisdictions listed there had their own free flu vaccine programs for 6 months to 5-year-olds. The good news for 2019 is that there's now been extended that all Aboriginal and Torres Strait Islander children basically from 6 months of age older are able to get a free NIP funded flu vaccine. And we've talked before about Katrina's amazing talk at the PHAA, which I think was in part that drove this change in advice and recommendation and the funding. Particularly important, as I showed before, that Aboriginal people who have double the risk of being hospitalised from flu and other Australians do get the chance to be protected, and the vaccine for the entire community will help them be, healthy and strong. In terms of Indigenous coverage, what we know over time is that it has slowly increased. So this is from 2008-9 up to 2017. Northern Territory has been a standout with sort of coverage up around about the 60% mark. You'll note there that we put an arrow next to Western Australia where the blue fell from 2009 down to 2017. That was in part driven by the flu vaccine febrile seizure story that we experienced nationally in that time point. So we're getting up there, and the Northern Territory is well above the rest of the jurisdictions. As I mentioned before, 2018, these jurisdictions introduced the flu-funded program, and they are again doing that in 2019. In fact, all states and territories are offering the free flu vaccine for these children in this age group. Frank Beard and Alex Hendry and Christine have just published this MJA paper, which is this is the title here: Early Success with Room for Improvement in the Flu Vaccine of Young Australian Children. Encourage you to read that. Frank has sort of given you the headlines there, and if you don't want to read anything else, 2 things I would have a look at is the graphs, but then that sentence there, which is probably the 3rd take-home message, and there's immunisation providers should offer the free annual flu shot for children aged 6 months to 5 years and report it on the register. Okay. So some of the key figures in Frank and Christine and Alex's paper, this is one of them. And this is over time from April 2018 to September in that flu season, and it's the proportion vaccinated. And what you can see that overall in Indigenous kids, coverage was 29.5%. So that's at best 1 in 3 of our Indigenous kids are getting the flu vaccine. Higher in the 6 months to 1-year-old age group, and that's probably the reason it's continuing to rise throughout the flu season, is probably related to new kids turning to the 6-month age group in that time point and therefore getting vaccinated. As shown here, Northern Territory is high at 61%, but other states and territories have got room to improve there. And it drops down as you get older. The 3 to 5-year-old age group is around about a quarter. Okay. So from 2017 to 2018, yes, good news. There was a doubling from 15% to 30%, but that's still only 3 in 10. Okay. For all kids, this is 6 months to 5 years again. The overall coverage was 25.6%. Again, the highest in that 6 months to 1 year age group at 36.5%. You can see there the states and territories, the highest being the ACT at 43%. So we have an increase from 5% in 2017 to a 5-fold rise to 2018, which is pleasing. If we go 5-fold increase again, that we're 125% coverage. 130. So we want to get that up if we can. Okay. So the take-home messages is that the flu season may come early. We are seeing some interseasonal flu. Okay, I can't ask you when we get asked by clinicians out there, how bad is this year going to be? 2017 was bad. 2018 not so bad. What's 2019 going to be? We don't know the answer to that. The only way to protect yourself is to get the flu vaccine. I hope we've shown you that The AUSVAC safety data is collecting rapidly, and it will continue to collect a large amount of safety data, and it's easily accessible on that website. The effectiveness of this vaccine will vary from year to year. Again, we can't tell you how effective it's going to be this year, but based on last year, it was a pretty good effectiveness. Okay. I think I've said this a few times. Our coverage does need improvement. We're only at the 3 and the 10 mark vaccinated, and it's our responsibility to recommend the flu vaccine, to make sure if you do give a flu vaccine that it gets entered onto the air. And as healthcare workers ourselves, we should be getting vaccinated to set the example. So we can do better, okay? Any flu case, in my mind, is a failure to vaccinate or a vaccine failure. Much more commonly, it's a failure to vaccinate, okay? How do we sustain the jurisdictional programs? Is that the best way forward? It's not on the NIP. To get onto the NIP requires a PBA assessment and cost effectiveness, okay? It may well be that it's on the NIP, maybe the coverage will go up. I can't answer you that one. Note that in the US and the UK, they've had flu vaccine programs for many years, not so much in the UK, but certainly in the US. And the coverage is 50 to 60% in those countries, so double what we're being able to achieve. So I've put it to you, and this is my fourth point. It's now time to remove the barriers, okay? The barriers in the past we've thought are people's awareness of flu disease and severity, people's awareness of vaccine safety and effectiveness. We've got really good tools to show you how a vaccine is safe. That should no longer be a barrier, okay? Awareness for that should be just removed as a barrier. Access probably does remain a bit of a barrier, but we can remove that. We can work towards removing the barrier. Previously, the barrier that people getting too many needles, I think there's, no longer is that really a barrier for hopefully for people. But Sammy and Holly will talk to you some more about what they're doing and what their research is showing about how, these are just my thoughts on time to remove the barriers, but they'll talk to you some more about what we can do best to get the coverage up. So I'll hand over to Sammy.
All right. Thanks, Nick, and thank you to NCIRS for inviting me to present today to share the findings coming out of my PhD on the attitudes about and access to influenza vaccination experienced by parents of children hospitalised for influenza. And today, more in particular, I'll be talking about the barriers that they face. Swap hands. So children and influenza. Young children historically, particularly those aged less than 5, have the highest rate of hospitalisation for influenza. That top line there on the graph is for those less than 5 years, which is then followed by the over 65s. More than half of the children hospitalised for influenza actually don't have comorbidities, though as Holly will discuss in her presentation, those with comorbidities tend to have more severe flu. As Nick has discussed, uptake has remained at less than 10% nationally for a while up until last year, where we saw a big increase with funding. However, overall, the majority of children aren't vaccinated, which means the majority of children hospitalised for influenza aren't vaccinated prior to admission either. So my PhD is embedded in a body of work currently being undertaken by PEDS through an NH and MRC partnership project, seeking to understand how or why children get severe influenza. More specifically, I'm looking at the failure to vaccinate, which is investigating the impacts of the individual, the interpersonal, organisation, community and policy levels on uptake. So how am I doing this? I'm talking to parents of children hospitalised for the flu because these families essentially represent the gaps in our public health system. As great as it is, there are gaps. In 2017, we undertook qualitative interviews with parents of kids hospitalised for laboratory confirmed flu. And then last year, we piloted a survey. And this year, we are repeating the survey. This time on a larger scale, inviting parents of both flu positive and flu negative hospitalised for acute respiratory illness. So people need capability, motivation and opportunity to vaccinate. And if they don't have one of these, they won't be vaccinated. And so what we found with through interviews with 27 parents of children hospitalised for flu in New South Wales and South Australia in 2017 was that they had a combination of limited capability, missing motivation and lack of opportunity. And you can see some examples in the square boxes next to them, but as an example, an absence of inclusive promotion for a lack of opportunity was particularly felt by parents of children who don't have comorbidities. They thought most of the advertising was for the ones with comorbidities, and so they didn't feel like they needed to get the child vaccinated because they weren't reading that. Therefore, child not vaccinated. So last year we piloted a survey from July to October during the first year that most states funded the vaccine for all kids aged 6 months to 5 years. And 75 parents completed the survey. 69 to 75 were parents of children aged over 6 months, and of the 69, 8, so 12% were vaccinated. So what you can see in this graph is in figure A, the parents' perception of ease of access to influenza vaccination. So up the top of the y-axis is very easy access, and down the bottom is very difficult, and then there's everything in between. Both the vaccinated, which are the dark boxes, and the unvaccinated, which are the light boxes, reported overall that they had easy access, but the median for the vaccinated group was significantly higher for parents being able to find a clinic with the vaccine in stock, and was significantly higher for vaccinated parents being able to easily travel to a clinic. Similarly, on the figure B, we've got strongly agreed, strongly disagree, and overall, both vaccinated and unvaccinated parents, thought they had easy access to influenza vaccination, though there were significant differences in the ease. So you might be thinking, if everyone's saying it's easy to get vaccinated, and if the vaccines were funded, why weren't they vaccinated? And it's because parents were missing motivation and had limited capability. So as an example, about 50% of the parents of unvaccinated children believe the vaccine causes influenza, and 43% were concerned about the ingredients. So it's not just access. So I can share with you data we've collected last month up until, this is data up until the 29th of April, of parents of children hospitalised for acute respiratory illness. So these are the barriers that parents are already experiencing this year. Keeping in mind, this is only with 30 parents of unvaccinated children aged over 6 months, so it's a small sample size, but still important to look at what's going on already. So at the individual level, over half of the parents had some degree of hesitancy about the vaccine, and then about a third have safety concerns. At the interpersonal level, the majority hadn't received a recommendation to vaccinate their child. The organisational level, about a third of parents are reporting difficulties in accessing it this year. And at the community and policy level, most parents can recall seeing information already this year, but 30% are unsure of whether their state provides free funding. And the most common sources they said where they're seeing this information are from commercial advertising, such as on the TV or posters in the pharmacy. And I think this is because I think today the government starts ramping up their communications on government programs. So that will likely change. So in summary, how do we increase vaccine uptake? We need to increase capability, we need to increase opportunities, and we need to increase motivation. Holly will talk more on the resources available to do this, but parents in my research have suggested that SMS reminders would help them. Information sent home from schools and childcare would help them, and a few would like increase opportunities for an in-depth discussion with a healthcare provider on the vaccine safety and efficacy. Thank you.
Hello, so I'm going to be focusing on that other 50% of the cohort, the ones with chronic underlying health conditions that unfortunately are visiting our hospitals, are often staying longer and having more severe outcomes for flu. I just want to acknowledge my conflicts of interest here, that I have received funding previously from vaccine companies. So we've spoken a lot about generally the pediatric program and about the kids who are now freely available to get vaccine. And that is a new and great and exciting initiative that has happened recently. But what we've actually got to remember, that there has been a cohort of kids that have been able to access free vaccine for a long time. And these are the kids with high risk, underlying health conditions. Free vaccination for this group is nothing new. This has been happening for a long time. And unfortunately, we've still got suboptimal vaccine uptake. So while we should be cheering on these increases, we know that free vaccine is not enough. So when I talk about kids with underlying health conditions, I am talking about quite a range of children in these categories. And this comes from the immunisation handbook. And we will have all seen this information before. So of course, we're talking about kids with chronic cardiac conditions, respiratory conditions, any neurological conditions, anyone who has an immunocompromising condition, those who have received a transplant, and of course those with Down syndrome or undertaking some sort of long-term therapy. So there is quite a range here in terms of the conditions, how long they've been dealing with them, and who's available for free vaccination. In terms of vaccine uptake, I'd like to thank firstly Chris Blythe over in Telethon for this slide. But we can see here the vaccine coverage across the states for the 2016 period. And in this space, we've got, with the yellow bars, the children with comorbidities, really vaccine uptake that hasn't been going above 30% nationally. These figures have been also supported in a couple of other smaller studies, state-based studies, which show really, we're talking about high 20s to 30s in terms of vaccine uptake. But look at the figures when it comes to the actual impact of flu. So going back to Sammy's presentation, yes, not all kids hospitalised with flu are going to have a comorbidity, but if they do, they're going to stay longer. They're probably more likely to end up in ICU at almost double the rate. So what is the role of the parent now in terms of trying to promote the flu vaccine and accept the vaccine? So we know, not surprising, parents who perceive their children to be at increased risk of flu are more likely to get vaccinated. So why do these children, who are the most at risk from flu and have more severe comorbidity from it, why is the vaccine uptake then so low in this population? Well, there have been a number of studies that have been done to look at what are the factors impacting uptake in this group. So we know that amongst parents and caregivers of kids with these high-risk conditions, that many of them are actually going to be aware that their children are actually classified as being at risk from flu. So it's not even just kids in general, but it's those with actually these high underlying conditions that are also unaware. And they are also unaware about the fact that there is a recommendation for their children to receive the vaccine. Even in this population, many parents think that the vaccine, that the disease is actually quite benign, that an illness is not going to have any huge impact on their children. And the fact is that even when you're talking about a group of children with underlying health conditions, parents put them on a spectrum. In this space, you may have children who you would classify as very unwell. But there may be other children whose condition is being treated and that they have no other symptoms and no other issues, and the parents actually think that their illness is under control and that they are functioning well with it. So that parent may not classify that child any different to a child who doesn't have that diagnosis or underlying health condition. So in many cases, these parents are perceiving the vaccine still to be optional for these children and less important than other vaccines. On the flip side, also, we have quite negative attitudes towards the vaccine, and this really kind of it resonates around safety, concerns around safety. Is the vaccine safe to receive for these children? And the idea here is really aligned to their concerns about the vaccine actually having an impact on the child's current drug regimen or their treatment regimen. Is it going to have some sort of interference with that, what the child is having otherwise for their health condition? So, like we've heard before from Sammy, that concern or that misconception that, you know, if you receive the vaccine, it's going to somehow kind of overwhelm the immune system and the child's not going to be able to cope with it. And also, of course, that kind of ongoing myth that this vaccine hasn't received sufficient testing, that it's a new vaccine compared to others that children receive on the National Immunisation Programme. A lot of those studies have been done overseas. And so we were really interested to have a look at, well, what do our Australian parents think? What do we know are the main factors impacting on vaccine uptake for Australian parents? So we actually did a study across 3 states in Australia to look at that question. So our study went across Queensland, Melbourne, and also into WA. And we surveyed over 500 parents and looked at vaccine uptake now a couple of years ago, back in 2016, 2017. And really we were interested in and looking at that kind of attitudinal issues around vaccine uptake. This work was undertaken by my PhD student, Dan Norman, in conjunction with Margie Danchin and Hannah Moore, Chris Blythe, and Paul Van Binder, and you can see the paper is actually available now. So we looked at vaccine coverage, and here you can see the coverage rates for 2017. So overall, we actually got an uptake of 52%, so slightly higher than what's been shown before. But remember, that could be a bias because of the population we surveyed. So we've got to kind of take that caveat into consideration. But look at coverage across the groups. That the information down the bottom is not the easiest to read, I apologise, but you can see that we have a couple of standout groups: children with chronic respiratory infections and those with multiple comorbidities were more likely to be vaccinated than some of the other groups listed in that space. Perhaps not surprising with the chronic respiratory infections, because really there are severe asthmatic children, where the teams that are looking after those kids, they see the end results of children coming in with flu. They know it, they live it, and so they promote it. In some of the other groups, especially some of the other diseases, it's not number one thing on the radar in terms of providers talking about it, and we don't get that uptake. So from our survey and amongst our Australian parents, we found that 50% had concerns about the severity of the flu. So that's really good. But then we've got 50% who don't think it's severe enough to warrant vaccination. About a quarter of our population had concerns about side effects, but those in the very concerned bracket was only about 12%. So that's important to note. So there is a spectrum there. And about half of our cohort believed the vaccine was at least 75% effective. So that's really good too. So there's something to work on there. But amongst those that were unvaccinated in our survey, we found that, just like Sammy's results, these kids had received no vaccine recommendation. They had not previously received, they had previously received a vaccine at a community clinic, or they had a caregiver expressing concerns about the side effects of the vaccine. In terms of the factors most likely to drive vaccine uptake in this population, of course, the number one parameter is that the child's previously received a vaccine, and that's a known factor now. If we can get them to be repeat customers, coming in, making it a habit, they are more likely to get vaccinated every year. So that's, we've got to work on that. But what I really want to point out in this particular study was this finding we came up, and this is quite novel. is that the hospital physician or the specialist had more influence on the vaccine attitudes than the primary care provider for these particular cohort of patients. So receiving a recommendation from a hospital specialist was going to be more impactful and potentially lead to vaccine uptake than receiving it from a community provider. Why is that? Because our parents spoke about the fact that these specialists understand the child's underlying health conditions. They have thorough knowledge about the drug regimen and about the safety and usefulness of the vaccine for this particular group. So they are a trusted source of information. It's not to say that the community provider, the primary care provider recommendation is also not important. I want to stress that, but our specialists are having more impact. Another thing I'd like to point out here, which is quite novel in our work, is that previously receiving a hospital-based immunisation leads to repeat customers. So if we can get them vaccinated on site, we could get them vaccinated again. So take-home messages. In our cohort of across 3 states in Australia, 50% of our kids with underlying health conditions didn't receive a vaccine. Many of the parents need some information about safety and need to have a discussion with a provider about safety. And that if we got vaccine clinics into hospitals, 80% of our cohort said they would have received a vaccine on site while they were there. And that recommendation from a hospital specialist is really powerful. So let's have a look at the role of healthcare providers in promoting vaccine uptake. This finding about the recommendation is nothing new. We know that. That can be the #1 factor that will lead to people to get a vaccine. The problem is in this space that we've got a lot of missed opportunities to make that recommendation. So in a study that was done in the US, they actually found that amongst high-risk children, so this cohort of children, over 70% actually experienced a consultation where they could have received a recommendation or a vaccine, but did not receive the vaccine. So we know that even though these high-risk kids are in and out of healthcare facilities, they may not necessarily be going into a primary care setting during their treatment. And this is often the case, that while kids are frequenting hospitals, they may not necessarily be going into primary care settings during their treatment. So what does that mean? It means that our messages for these high-risk kids need to be happening by hospital specialists and happening while they are on site. In many settings around Australia, we can't currently deliver vaccine to kids while they are in the hospital setting. Some of our big hospitals, like the one I'm standing here at Children's Hospital at Westmead, has that capacity to actually deliver vaccine on site, but many of our other sites don't do that right now. But that's not to say we couldn't be doing other things. Based on these findings, what we are suggesting is that all hospital specialists should at least be talking to their patients and their patients' family about the flu vaccine. Should be starting to kind of get that groundwork in about the need for vaccine. If they can't deliver it on site, then the recommendation should be to send the child, of course, to the primary care setting for the vaccine to be received. However, what we would stress in that space, if you are going to send a child off site, perhaps consider sending the parent home with an information booklet or with a printout that says, I have spoken to the child's parent, the child is eligible for the vaccine, there's no reason why this child can't get vaccinated. So that if the child encounters a primary care provider who perhaps is uncertain about the child's underlying drug regimens or the treatments that they are having and has some uncertainties about whether they can get the vaccine, that we don't have that clash of ideas between the specialist and the primary care provider. What is the problem still in all of these spaces is that we know that in our hospital settings, we still have a lack of understanding amongst our providers about these recommendations. So in some work that I was involved with a couple of years ago, led by Jim Newcomb, we actually found that only about 50% of the paediatricians that we surveyed actually understood what the current recommendations were for Australian children. There was a lot of confusion about kind of who should be providing the vaccine. And there was also a lot of confusion about actually identifying who is classified as a high-risk child in this setting. Even amongst healthcare providers, they also may actually rate influenza down the list of vaccines to receive. So they also may not think it is as important to receive as maybe other vaccines in this setting. And it may be also here, especially with children with multiple comorbidities, that the provider is needing to talk about other things, and so talking about a vaccine may be relegated to another time, or to a quick conversation at the end, and that may not be good enough. So how do we improve it? There's been a lot of talk about the fact that we could use SMS, and that could be one strategy. We could definitely use posters that promote the vaccine, and especially posters that are in different languages and show the different patient groups that we have in Australia. We could have pop-up reminders within the systems that are used in hospitals and primary care settings, and we could also send people to frequently asked questions. But in the long run, really what we need is our healthcare providers in both the hospital setting and in the primary care setting to start saying to their patients, your child, insert name, needs their flu vaccine today. A direct statement. We need to move away from saying, oh, have you considered getting your child X vaccinated? The new language is about using a direct approach. What do you think about that? What I would encourage anyone to do, especially if you have any concerns about how to address and approach a parent who you may think is got some sort of hesitancy around the vaccine, and you want to prepare for giving responses to parents, is that you use the great resources that we now have available. I've put up the SCIES team's website there. I know this is the one for parents, and the provider website will be coming shortly, so watch that space. In the meantime, there are great resources from the CDC and also the WHO about addressing hesitancy for parents, and I have put the websites there. So thank you for your time. As a last plug, I would like to encourage anyone who's interested in social science to jump on our website for COSI, especially anyone who's considering research and maybe not sure how to approach it. We are very welcome to collaborate with healthcare providers around Australia. So I've put the website there. So thank you very much.
I'm going to invite all three speakers to come up here. So please stay here, Holly. Thank you so much. That was excellent. And thank you so much to Nick, and also a special thanks to Sammy, who really had about 24 hours to prepare for this. And so I think we should give her another round of applause as a PhD student. So when it's only the 1st of May and you show data from the whole of April as a student, that's just fantastic, including also the AusVac safety data. So just another plug for the AusVac safety team. That data is uploaded every single Friday. And of course, now that we're rolling out flu vaccine to a much greater extent, when you look at the numbers that'll be posted this coming Friday, I'm not sure whether our team could shout them out right now because we're still in the process of downloading the data, but we do look at it every day, and it'll be in the many thousands, those numbers that Nick showed, by Friday afternoon. So I think we are right on the bell. I'm looking to the conveners here to see if we should say goodbye to our online audience. Are there any other pressing questions? We know some people will be signing off. No, I've been given the all clear to say goodbye to the remote audience. But just before we do say goodbye, I'd like again for all of us to thank Associate Professor Nick Wood, Dr. Holly Steele, and soon to be Dr. Sammy Carlson.